This is a 45-year-old female who presented with bilateral infarcts. The right internal carotid artery injection was normal. The left ICA continued as the ophthalmic artery. There was a PCOM that was subserving the left internal carotid artery, but it was poor and there were leptomeningeal collaterals to the left ICA territory. This patient presented with recurrent stroke 6 months later with a larger infarct on the right MCA. Repeat DSA showed there was narrowing of the terminal ICA with severe stenosis of the right M1 and some stenosis involving the right A1 origin. Vessel wall MRI was reported as vasculitis based on concentric enhancement and thickening of the petrous and lateral segment of the ICA. One has to be extremely careful before reporting vasculitis, as most cases reported as vasculitis turns out to be atherosclerosis. Therefore, the question is whether this was vasculitis or not. Look at the sagittal T1 post-contrast imaging. There was eccentric thickening and enhancement that was grade 2, that is equivalent to the pituitary stalk. Whenever there is a confusion between atherosclerosis and vasculitis, it is important to look at the T2 sequence. You notice the red arrow pointing at the lumen and the blue arrow pointing to a T2 hyperintensity suggestive of a fibrous cap. The enhancement of the T1 imaging corresponds to this fibrous cap. The red shade corresponds to the lumen and the blue shade corresponds to the fibrous cap. The yellow end corresponds to the fat, and it appears hypo on T2 because it contains cholesterol and cholesterol esters rather than triglycerides. Therefore, whenever you see a T2 juxtaluminal hyperintensity, it is suggestive of a fibrous cap and it refers to atherosclerosis and not vasculitis. Whenever there is ICA occlusion, the vasovasorum can proliferate in the extracranial ICA, and enhancement in this segment does not contribute to the diagnosis. One cannot call it vasculitis based on this.